Good morning. It is January 25th. This is the Senate Health and Welfare Committee meeting. And this morning, we're going to be looking at the ALS Registry Bill S90 with Commissioner Levine, who is available until 10:30. And then we'll be moving on to the budget adjustment as it affects human services issues. Dr. Levine, welcome. It's a pleasure to have you here. I think we're very interested in moving forward on S90, but would like to hear your comments first. I know that you don't have anything in writing at this time, but we'll see as it goes along if there's something that you can provide to us that would be very helpful.
I will have something to provide for you.
Terrific.
Should I begin with some opening comments?
Yes, please. Introduce yourself for the record, and then it's all yours.
Thank you, Madam Chair. Mark Levine, Commissioner of Health. I want to say at the outset that I really come to this committee with the utmost of empathy and humility regarding this devastating disease, ALS, which has no known cause and causes such significant morbidity, mortality, and family distress. I also have an element of personal involvement. As a practicing general internist, I have diagnosed this condition twice in my own patient practice, which is a bit above the odds, and suffered the loss of a close family friend out of state just in December. I want to clearly provide for you, though, a perspective on the proposed legislation. Let it be too optimistically, if I could say, embraced. And too optimistically presumed that if we only had a registry, that is the missing ingredient and the pathway to successfully understanding the disease and moving closer to understanding causality. Well-designed epidemiologic studies need to be conducted in order to get us closer to understanding the causes of ALS. A well-designed study would be one without bias and which would account for potential confounders. Clearly, more research in this area is needed. The department supports quality epidemiological research into the causes of ALS. We are aware of spatial analysis, ecological studies that look at the association between ALS and cyanotoxin. There are many weaknesses with studies like this, so it's challenging to draw strong conclusions from these. It's not clear to me that a registry is the best way to approach that research in Vermont. So let me tell you why. Registry data does not collect information on risk factors such as occupational, environmental, and lifestyle risk factors. For example, in a study that Dr. Stommel and colleagues published last year, they found an association between pesticide exposure and ALS. Studies have also shown associations with heavy metals, head trauma, smoking, and in a small percentage, probably under 10%, there may be a genetic predisposition, among other things. So if the goal of a registry is to determine a cause of ALS, the registry may not provide the information needed. Data on risk factors, demographics, and other potential exposures would need to be collected as part of a well-designed epidemiologic study. These are not data that physicians typically collect, and therefore they can't be reported to the health department. As an example, in the Massachusetts ALS registry, the following data are collected: patient demographics like age, gender, address, clinical symptoms, and laboratory data. Diagnosis and treatment. Massachusetts received funding from both CDC and the ATSDR, which is the Agency for Toxic Substances Disease Registry. Additionally, the number of cases of ALS in Vermont, as we all know, is relatively small, which makes deriving meaning from the data challenging due to a lack of statistical power. Now, it may be true that collaborative epidemiological studies involving larger populations, such as combining reports from multiple states, or registries, such as the National ALS Registry, may yield more promising results in a disease as uncommon as ALS. The National Registry is a separate and voluntary self-report registry created to identify and gather information about ALS from cases throughout the US. We could ask healthcare professionals to encourage patients to report here. There's an exposure questionnaire that people can fill out or opt out of. As an example of something I believe would be equally helpful, let me describe the breast cancer surveillance system approach to research. The Vermont Mammography Registry is part of the Vermont Breast Cancer Surveillance System and a partner of the nationwide Breast Cancer Surveillance Consortium. Leading scientists from across the country and in Vermont joined together to study breast cancer screening and diagnosis. The Vermont Mammography Registry is a partnership of 13 facilities across the state that conducts quality research on breast health and mammograms. Based out of UVM, every time an individual gets a mammogram, a questionnaire collecting risk factors, demographics, and other data is completed. And these data have contributed to hundreds of quality published studies on breast cancer screening. I could envision a quality epidemiologic study working with neurologists in Vermont being done in a similar fashion. An approach where researchers reach out to Vermont neurologists to ask their ALS patients to take part in a research study that collects data on demographics, risk factors, and exposures with a validated questionnaire. Finally, a disease registry for one disease does raise issues of equity as well. Currently, the only disease registry in our state is the Cancer Registry. No other disease has a registry. Registries are generally utilized to track clinical care and outcomes. Our Cancer Registry is designed to reduce the impact of cancer on individuals, families, and communities. Data is submitted by physicians and not patients. There are even other more common and often similarly devastating conditions that do not have a registry. While the financial, logistical, and human resource challenges of establishing a new registry need to be considered, I certainly don't consider these to be insurmountable or large. And to go on record, since this appeared in the press, concerns about the impact of tourism related to cyanotoxin in our lakes has never been a consideration from the Department of Health regarding support of an ALS registry. But in conclusion, I do worry that the admirable goals that the advocates for this registry have would fail to be realized in consideration of the uncommon nature of the disease and the issues of lack of comprehensive data to allow comprehensive hypothesis testing that I have described. Be happy to take some questions now. Thank you.
Thank you very much. And if we can get something in writing from you, that would be very helpful. In particular,
you'll have it this morning.
Yeah, that would be great. I think the iteration of the various possible epidemiological analyses that could be carried out and what your thoughts are there. And if you can link those or any one or more, your preference with cost associated with that, how that might happen. The other issue, and then a question I have, and I know others will have questions as well. Let me clarify, you indicated that the cost and the human resources involved in a registry is not a significant barrier. Okay, thank you for that.
No.
Yeah. Then the question I have is, I know we have the breast cancer, the mammography surveillance system here in the state. And as I recall, when that was initiated, it was a result of identifying a high rate of breast cancer in our state. So it was, and I don't know how that happened. I mean, that was not an initial registry, it was a reporting process. So how did that occur?
That's quite a number of years ago.
Yeah, it was.
So I can't, I don't want to misaccurately represent its history because I'd have to go back and look. Certainly predated me.
Oh dear. I remember. Okay. Hold on a sec, Senator Hardy, just 1 minute. And then the other thing that you brought up was the number of cases in Vermont is relatively small. So the relatively question I have is based on what population? Obviously, there are concerns, and we'll hear from folks. You mentioned Dr. Stommel. We will hear from him and others who are concerned that the case rate is high for the small population that we have. And you indicate that the cases are small. And what are you basing that on? What population?
Yeah, so incidence rate of 2 per 100,000.
Okay. And we don't have that in this state. Although
No, that's what we do have.
That's what we do have. Oh, I'm
Yeah.
sorry. Thank you. Okay.
Yes. So that would be 12 individuals a year, and then average life expectancy 2 to 5 years. So the prevalence would obviously be higher than that at any one point in time.
Okay. Thank you. Senator Hardy.
Thank you, Madam Chair. Good morning, Dr. Levine. Thanks for being with us yet again. I'm curious the logistical differences between the breast cancer surveillance program and a registry. Like I've participated in the breast cancer surveillance program, but I don't think I understand the difference between that and a registry. Would you explain that a little bit better?
Yeah, so the way the breast cancer surveillance system works, it's part of a consortium across the country. And within it is a registry for patients who are engaged in mammography. So it's sort of an automatic questionnaire that would occur to help understand some of the factors that come into play with regard to breast cancer's etiology, et cetera. So it is not an independent disease registry, if you will. It's a registry regarding the procedure.
Oh, I see. So, but it's part of a Vermont's sort of sub-program as part of a national
Yes.
Thing. Okay, because I hear you about the small sample size. That is, of course, always the problem with Vermont is we're on almost every measure a small sample size. Do you know of any regional registries for any disease? Like if we had a New England registry, I heard that, I understand that Massachusetts has an ALS registry. Do you know of any diseases that have any kind of regional registry?
I do not. This would be an ideal one, to be honest, since we have researchers from Vermont and New Hampshire already, and just extend that further in northern New England to Maine, then you'd begin to have more of a sizable number, though it would still suffer from some of the concerns I had with regard to understanding the causes if that data wasn't present in the registry.
Right.
In the reporting that physicians did when they put patients' names into the registry.
Is there a way to do sort of the like the breast cancer surveillance data collection with a registry, or is that sort of
I think that's kind of epidemiologic study that I would be looking for. And the neurology community is not a large community. I mean, there are not as many neurologists in the state of Vermont as there are family practitioners. So I would think that enlisting the cooperation of a specialty group across several states might not be as challenging a job as trying to get every physician, enrolled in something.
Right. Yeah, that makes sense. And you said there's a voluntary national registry for ALS.
Yes.
I wonder if there's any way we could tap into that more and sort of say, is there a way to like require that Vermont participate in that in some way?
Yeah.
Or does that defeat the voluntary nature of it?
Well, it defeats the voluntary nature, but also that's a patient-centered registry. So the patients actually are encouraged, hopefully by their clinicians, to register in that registry to contribute to the database across the country. And that one does have some opportunity to understand cause and effect. The Dr. Stommel and Dr. Tandon and I, a couple of years ago, did talk about that registry and the shortcomings of the process with not having enough ability to get all the patients enrolled, and with, I think from their standpoint, not being able to access perhaps the data to analyze.
Okay.
But they'll be able to share that with you more. I don't want to try to represent their thoughts on the registry. I think they think it's a great idea.
Right.
But there's no physician input into the registry. It's purely.
And one final question, Madam
Go
Chair.
ahead. Sorry. Go ahead.
So I hear you on the health equity question, sort of once we have a registry for one disease, why not another disease? And that is concerning because I don't want to have a bill every session of a new registry. And, it also sort of prioritizes one thing over another in a way that's uncomfortable for people who are diagnosed with a terminal illness, or more than uncomfortable. That's not even the right word. But I'm wondering, do you know of a sort of other solution that would be more holistic at looking at groups of diseases like neurological diseases or terminal illnesses or chronic diseases or whatever, however you would group it? I'm not a doctor, you are, but so that would be more holistic.
Yes. So, even our one big registry, the cancer registry, it's cancer. So whether it's breast cancer, or gynecologic cancer, lung cancer, you name it, it's all in the registry. And there are sufficient numbers of neurologic diseases that actually don't occur in high numbers, but occur, that it would make sense, perhaps across several states, to do something of that sort. We know that in northern states, diseases like MS are more prevalent, and other neurologic diseases that are pretty common, like Parkinson's, which has had a lot of work done to identify causes, but not totally satisfying in the end. Those could all be clustered together into a registry and perhaps get a bigger bang for your buck, if you will.
Yeah. So is there, just thinking out loud here, a possibility of maybe us saying, requesting or requiring that the, Neurological Association or the Department of Health, or I'm not sure who we would require, to work with people in the New England region to create a proposal for a regional registry for neurological diseases, something like that.
Yeah, I know you. Am I the first one testifying on?
Yeah, you are.
Yeah,
so I'm asking
you are.
And that's great. So I would hope the neurologists who will follow me will be very enthused about thinking more broadly, if you will. But I can't answer for them. But certainly that is a possibility. But again, even there, as you point out, Senator Hardy, we're then selecting cancer and neurologic diseases for what we're going to do in Vermont, to the exclusion of many diseases that are far more common in the population. So again, we have to think about why we want a registry. And
Yeah.
if it's for understanding causality, that's one thing. If it's for understanding what our clinical outcomes are and how they could be improved, and how our clinical care processes could be modified, that's certainly other great reasons. Whether it's surveillance, that's another reason. So there's a whole host of reasons, and we just have to have the right rationale surrounding our choices.
So,
Okay.
yeah, thank you.
Thank you.
Other questions? I guess I was leaning in the direction of trying to, I mean, I made a distinction right in the beginning, as you were testifying, that we can look at clinical treatment improvements and we can look at causation, epidemiological information. And I guess I'm going to, we've talked a little bit now about the surveillance piece, which leans toward clinical treatment. But my question is the Department of Health interested in spearheading an epidemiological analysis of whether it's a number of neurological diseases or ALS separately? Is there an appetite in, and I know that I know where we are. I know we're in year 3 somewhere, but going forward, an epidemiological analysis of one or more of these issues, and particular ALS, since that seems to be of such huge interest in our state.
So clearly when we do our literature analyses, the one factor that seems to be missing from most of the ALS literature is the epidemiologic angle.
Yeah.
In terms of contributions to some of the research publications, for instance. Clearly in Vermont, we have a select group of epidemiologists who all have major tasks in terms of major infectious diseases that they're accountable for, et cetera. So this is not an area of expertise we would have in-house at this point in time. We have epidemiologic expertise, but in terms of specifically looking at these neurologic diseases and having the requisite manpower, I would envision that much more in a collaborative effort in a research project that doesn't necessarily have to be based in a registry.
Yes, but it would be a research project. That's what I was alluding to. And then the cost of that, whether it's through, certainly the Department of Health would want to be somehow advising or engaged in that, but also where can we find anyone in our state or a neighboring state willing to take on that it's a longitudinal process, no doubt. So
Right. So there'd have to be significant search for grant opportunities and acquisition of grant funding to pull that off.
Okay. All right. This is very helpful.
Not impossible. Yeah. Just
no, it's not. It's not impossible, and it's certainly, if Massachusetts already has a registry, they may have reached a level of frustration around causation. Who knows? I don't know.
Can't speak to that.
No. Do you know that? You don't know that. Okay.
I don't know that.
Okay. Committee, other questions? This really is very helpful. This is the first opportunity to hear about the registry, and it was important, I think, to hear from Department of Health. So, Senator Hooker.
Yes, thank you. And thank you, Dr. Levine. I appreciate your comments because it seems so easy to think, we should have a registry for this devastating disease. And you commented that the goals of the advocates may not be realized. And I'm assuming that that's because of the number of cases we have, that there's not enough information. Is that what you're referring to?
Yes, number of cases, the fact that the kind of data that they would be looking for to help with the issue of causality may be limited to where an address is, and is it in proximity to where cyanotoxin could be in the state, versus actually a more firm understanding of all of the risk factors and exposures that the individual patients might have had. because that information generally won't be available or put into the registry. So that's a concern. And the whole topic of really hypothesis generation versus hypothesis testing. It's one thing to be able to generate the hypotheses, which abundant ones have already been generated, as we've discussed, but to actually test these hypotheses would require a much different tool than the registry.
Thank you.
Okay, this is very helpful. We may bring in, we will definitely be bringing in folks who are Dr. Stommel, who you mentioned, and his colleague, and others. And then I don't know if you're familiar with Dr. Cram at UVM and his data work that he's doing.
Dr. Cram?
Yes.
I'm not familiar with this.
Okay,
one.
that's all right. He's actually retired now, but he's doing some interesting data collection review work. Oh.
Hmm.
All right. May I introduce you to him?
Well, that would be great.
Okay.
Um,
All right. Any other questions? Senator Cummings? All set? Okay. Senator Hardy, Senator Hooker. Dr. Levine, thank you again. We welcome your testimony, and anything that you can provide in writing would be greatly appreciated.
We'll get it to you.
All right. Thank you.
Thank you all.
Okay.
Always glad to be with you.
Good, because you know this isn't the last time.
I know that.
All right. All right. Take care.
Bye-bye.
All right, so we are going to move on. Committee, Aaron, why don't we have Sarah Clark come in to the committee meeting, and we're going to move on to the Budget Adjustment Act. I'm hoping that we can save just a little bit of time before the meeting ends today, just to I have a couple things I wanted to go over with you. Not a big deal. And the planes are going over me right now, so I may not be able to hear anything. Okay. So, Sarah Clark, welcome.
Well, thank you
And-
very much.
And congratulations are in order as a member of our joint fiscal office. We're very pleased.
Thank you. I'm very, very pleased to be here myself. And I was just reminiscing this morning how I got to spend some time with this committee over the last couple of years in my former role at AHS. And it's a pleasure to be with you today as the deputy of the Joint Fiscal Office.
That's terrific. And I know that you and Nolan Langwell will keep us on the straight and narrow. I greatly appreciate your being here. So we have some information from you on what's in the Budget Adjustment Act. And why don't we allow for you to take us through it? And I think we'll allow for interruption for questions of clarification. Is that okay with you?
Yeah, that sounds fine.
Okay, and we'll try to hold a broader discussion until after we've been through the whole thing once. We don't want to go too far afield until we get the whole big picture. So,
Great.
Are you going to share screen or?
Yep, I'll go
Okay,
ahead and
great.
do that. Can
And we
everybody
also have it.
Yep. Okay, great. Good morning. For the record, Sarah Clark. I'm the Deputy Fiscal Officer of the Joint Fiscal Office, and I'm here with your committee today to talk about the human services related areas that are included in the FY22 Budget Adjustment Act as voted out by the House last week. The document that you see before you is a highlights document. I adapted it for one we use for the overall budget adjustment request to just focus on the specific areas in the Agency of Human Services. So with that, I think I'll just start walking the committee through the document. So from an AHS-wide perspective, there are really kind of two larger proposals that were included in the House passed budget adjustment last week that I want to focus on. The first one is a funding for a workforce retention program in several critical areas. The first, you'll see this in 1A, is related to healthcare, where $60 million of funding was provided for retention-related payments to shore up critical provider systems in some key areas. Those areas include assisted living residences, nursing homes, residential care homes, home health agencies, and the DAs and SSAs, as well as with substance use treatment providers, recovery centers, and the independent direct support workers. That $60 million represents a blend of funding to include state and fiscal recovery funds, global commitment Medicaid dollars, as well as an opportunity you're probably familiar with, the Home and Community-Based Services FMAP bump. The intention behind the program that the House passed is essentially the Agency of Human Services will administer a grant program where the eligible providers will provide to AHS the number of FTEs in these specific areas. The intent is that each FTE, the grants will be awarded based on a $3,000 per FTE basis. If within that $60 million, there is not sufficient funding, the Agency of Human Services will be able to prorate the amount of the grant award. So it may be based off of less than $3,000 per FTE. However, it was also important to the House that these organizations have some flexibility in terms of how they, once they receive the grant based off this per FTE amount, that they have some flexibility in terms of how they administer those dollars. And so that was made clear in the language. These organizations will have 12 months in which to distribute these funds to the employees in their organization.
This is an employee-based grant, so it's for
Correct.
the workers themselves.
Yes, exactly.
And
To
it's
deal with
not,
some of the workforce challenges that we've been experiencing.
Yep.
Yes.
so it's not based on number, we don't, that's okay. I don't need to ask this question now. Go ahead.
I think it's maybe helpful for you to understand. So this is what the House proposed. It's different than what the administration proposed. The administration's original proposal was for $33 million in total. Of that $33 million, it was going to be a kind of competitive application-based process in which they would administer the funds. So the House increased the amount as well as changed the methodology by which these retention payments would get to employees. So in addition to healthcare retention, there is also a similar program for childcare workers with a $6 million state and fiscal recovery fund appropriation designed to provide some critical retention payments for childcare employees. There's also, and I know that this committee doesn't necessarily look at Department of Corrections items, but just for some additional context, for state employees within the Department of Corrections, the Department of Mental Health, and the Vermont Veterans Home, there is also funding state and fiscal recovery funds to support retention proposals per the collective bargaining agreements for those employees. So it would be your correctional facility employees, your employees at the Vermont Psychiatric Care Hospital, the Middlesex Therapeutic Care Residents, as well at the Vermont Veterans Home.
Do you have a sense of, obviously, Department of Corrections has its own contracted health care. Is there anything in, does this dive as deep as healthcare within corrections, or is it simply corrections employees via
It would be the corrections employees, so state
Okay.
employees, not the contracted healthcare resources.
Got it. Okay.
So that's
Sarah, Senator, if I could.
Yes,
Yeah.
go right ahead. You're
Okay,
good.
we're looking at like retention bonuses. This is a one-time payment to these employees offered by the employer.
that is correct.
Okay, thank you.
Okay, moving on from the retention proposal, there is another kind of large bucket of funding that was included in both the governor recommend budget adjustment and the House recommend budget adjustment, and that is $25 million general fund appropriation related to COVID-19 pandemic response and giving the Agency of Human Services the ability to continue to respond to emergent and exigent circumstances related to the pandemic. If you recall, AHS administered something that we called the Healthcare Provider Stabilization Program. In a lot of ways, this funding is a continuation of that program, but a little bit more targeted in some key areas. So under 2A, I'm using the AHS lingo of known costs, and that is roughly $15 million in these three areas to provide capacity for subacute beds, ICU capacity, as well as some contracted staffing supports through the TLC contract, which is a staff augmentation contract primarily for nursing and related types of services that has been utilized to help do some targeted resource inflows to some providers that needed assistance as the pandemic has continued to evolve and impacted our capacity within the healthcare system. So that's the first $15 million of this $25 million package. The balance of it, $10 million, is intended to provide provider emergency relief. So as providers experience emergent needs where without financial intervention, they will either have to reduce their capacity or potentially contemplate closure, these funds are meant to address those needs. And so really,
I'm looking at the subacute beds and then listening about the provider emergency relief. When we're talking about subacute beds, is this directed more specifically toward mental health treatment? And then do you know what if any direction toward Brattleboro Retreat, for example, to ensure that, or to our DAs where we have a need for step down beds right now, pretty acute needs for subacute treatment.
So what this is specifically focusing on, I believe the Agency of Human Services has contracted with 7 long-term care facilities to establish bed capacity.
Okay.
Though I will say, and I can provide to the committee if you have not received it, the Agency of Human Services has provided a more updated accounting of how the previous healthcare provider stabilization program completed, and that they did continue to issue awards for emergency situations, and there was additional funding that flowed to the DAs and the SSAs, as well as to the Brattleboro Retreat. So you'll find some of those details there.
If you can get that to us, that would be terrific. You can just send it along to Aaron and he can post it for us. That would be great.
Will do.
Thank you.
Okay, if there are no more questions there for now, I'll move on. Okay, so then within the Secretary's office in the budget adjustment, there is a net neutral shift of the 211 contract from the Agency of Human Services to the Department for Children and Families. This doesn't have a budgetary impact, but important to understand that the management of that resource, which has primarily a focus on emergency housing and connecting Vermonters in need to the right resources, that's moving from the Secretary's office to the Department for Children and Families, which in reality, it's been a partnership of management over the years. And I think this really aligns the contract with the direct management. And so they're moving that to the Department for Children and Families. And in the Secretary's office, you're going to see some general fund carry forward being used to pay for some additional technical assistance on the 1115 global commitment waiver, as well as the all payer model waiver. I believe this committee is aware that both of those waivers are in the kind of negotiation phase with the Centers for Medicare and Medicaid Services. In the Department of Vermont Health Access, this budget adjustment funds Medicaid caseload and utilization increases of $67.5 $6.5 million gross. What we're seeing in Medicaid caseload utilization with the continuation of the public health emergency associated with the COVID-19 pandemic, states are not able to do redeterminations. That's part of the bargain, if you will, with the acceptance of the 6.2% FMAP bump that has gone to states to help Medicaid programs through the pandemic. And so we are seeing an increase in our Medicaid caseload related to that public health emergency. Budget adjustment fully funds that increase. In addition, in the DIVA budget, you're going to see adjustments to Medicaid rates for participating Medicaid providers, which reflects a $4.7 million gross increase. This is a continuation of DIVA's stated intent to continue to professionalize their rate setting process and align rates with existing methodologies.
You know how at some point, not today, this is not a question for the BAA, but the alignment of the Medicaid rates with the PPS for FQHCs. Is there any link there? Well, that's a question for you. You don't have, it's just a question without an answer right now.
Nolan and I will note that and perhaps come back in the future.
Thank you. Okay, terrific.
Madam Chair, I have a question.
Sure.
Sarah, you may have just said this and I missed it. I'm trying to take notes and listen at the same time, but the number 7, the calendar year settlement, could you explain that?
Sure, and that's actually where I was going to go next. So this,
good. Okay,
it's a great lead in. So the budget adjustment includes funds for the calendar year settlement with the Accountable Care Organization, the ACO, due to the contractual risk sharing that is established in the agreement that DIVA has with the ACO. And so those funds, I think it's roughly $15 million gross, are included in the budget adjustment.
What does that mean?
Sure.
The contractual risk sharing arrangement.
So essentially DIVA enters into a contract with the ACO to, provide for the Medicaid services for the attributed lives in the ACO over a calendar year. So as part of that contract, DIVA and the ACO agree upon the price of healthcare for the attributed Medicaid members up front at the start of the contract. At the end of the performance year of the contract, there is a reconciliation that happens. So for calendar year 20, the spending for the members attributed to the ACO was less than the agreed upon price in the contract. And so therefore, as part of the reconciliation, DIVA pays the ACO per the agreed upon price in the contract.
Wait, but if it was less than the amount, why are we paying the ACO?
What DIVA paid was less than what the agreed upon price in the contract was. And so, but they're still required, because of the way the risk sharing arrangements work, they're still required to pay that $15.4 million. And you may recall in some years, it actually works in reverse, where the ACO has had to pay DIVA money back because of the risk sharing agreement. This is the year in which DIVA owed the ACO money.
And is it because there was less healthcare utilization, or is it because?
I think, unless Nolan has more details to share, I think that I'd prefer to come back to you after following up with my colleagues at DIVA, just to make sure that I'm responding appropriately.
Yeah,
okay, that'd be great.
We'll do that. This is a question, of course, that has come out in the media, and because of the payment to the ACO, and in the past it's been silent because the ACO has paid us back. So we'll have to look at that risk sharing agreement again and understand exactly what it means. So we're clear. So good question, and we'll follow up with that. Sarah, thank you.
And
Just let us know. Let us know, perhaps through Nolan, or you can let us know when you're prepared. We can do that.
Sounds good.
Senator Hooker, I see you.
I'm here. Thank you. Sarah, there seem to be adjustments made because of the pandemic in other line items. Will there be any adjustments made in this particular line item because of the pandemic? I mean, as Senator Hardy pointed out, was there less utilization because people just weren't getting the care, or are they really, are we really doing a better job? So that's something that I hope that we can ferret out.
Yes, I think that's a good to include in the additional conversations on the reconciliation process.
Okay.
Okay. Then I will, I think, move on to item number 8, which is there are funds in the budget adjustment for the increase in buy-in. As this committee is likely aware, buy-in is a program where states are allowed to buy into Medicare for their dually eligible Medicaid, Medicare enrollees. And there was a roughly 14% increase in budget adjustment. I think it's important to remember that it's still kind of overall cheaper for the state to participate in the buy-in program, as opposed to whether those individuals were actually within Vermont Medicaid. And then there is an increase related to access to care and per diem rates in emergency departments that's designed to reduce some of the wait times that we have seen in emergency departments.
Is this related primarily to mental health? I'm going to focus on mental health because I know it's a huge interest and also concern.
I don't think it's specific to mental health.
Okay.
More kind of the overall issue in emergency departments.
Yeah, we've seen it. Okay.
Yeah. So that's the kind of the highlights associated with Department of Vermont Health Access budget adjustment. Moving on to the Department of Mental Health, there is roughly $150,000 of general fund to help pay for some of the startup costs for the new secure residential that is, I think, under construction or in various, whatever phase it's in the new Essex location. And then there is another $440,000 of general fund to maintain the 988 suicide prevention line within the Department of Mental Health. For the Department for Children and Families.
Wait, I have a question, Sarah.
Go ahead.
Thank you, Madam Chair. For DMH, I guess I'm surprised that there's not more, given that we heard so much about mental health, and I realize there's that funding in the AHS wide thing, but I know I know this isn't your budget, so you're just telling us what's in it. So, yeah. But do you know if there were conversations about other requests, other items that may have been in there that didn't make it in, or I'm just surprised there's not more.
Yeah, I think as part of this conversation, we should also just say, and the FY23 budget was just delivered by the governor last week. And so I think that you're going to see when you dig into the details of the 23 budget, that there are more investments in the areas of mental health. So for example, in the 23 budget, the governor's proposal includes a 3% rate increase to a variety of providers, including the DAs and SSAs. And so I think some of the investments that you're thinking of will hopefully either have been considered in the governor's 23 budget, or will be something that we'll continue to have conversations about.
And I think there's also a grants program going out to fulfill some obligations through the Brattleboro Retreat and others. So when DMH comes in, we can follow up with questions either this week or next.
Okay.
So moving on to the Department for Children and Families, you're going to see funding in the budget adjustment for adoption and foster care caseload increases. There's also $6.1 million in the Office of Economic Opportunity for essentially 3 different purposes, all related to emergency housing. One is an increase for rental risk mitigation. Then there are some funds for transportation for general assistance clients, which is basically to be able to bring individuals to where there is housing in the state. And so there's additional funds for that, as well as funding for rapid resolution housing, which is a program that's designed to kind of meet some immediate needs of homeless Vermonters. The biggest part of the $6.1 million is the rental risk mitigation, which is in total a $5 million appropriation, which is designed to help facilitate moving Vermonters into rental relationships and providing some additional supports to landlords to be able to provide housing opportunities to Vermonters.
So does that include the rental rebate program?
I think it's its own unique program.
Its own unique? Okay.
Yeah.
Okay.
The next item, if you looked across, DCF has many different appropriations. There's a variety of kind of small adjustments to align expenditures to actual what they've been spending over the last couple of years, as well as some earning adjustments, all kind of relatively small dollar, but you'll see it in a variety of places in the Department for Children and Families. The budget adjustment includes a savings of $814,000 of general fund due to underutilization in the subsidy caseload program in the Child Development Division.
Can I ask you, Sarah, that's a real concern. I think underutilization, where is this money going? It's just a concern that we're not holding on to it and using it as demand is increasing.
Yeah. That was also a conversation that the House had about this. I mean, I think for state fiscal year 22, the underutilization is kind of the trend that DCF is currently seeing. I know that as we move into state fiscal year 23, they are working on making that underutilization go away and actually have, increased investments in this area because it is a priority for them.
So what's happening to the money? I mean, once you throw it away,
Sure.
It's hard to get it back. So next year, how do we get it back?
So DCF did not adjust the base budget in 23 for these savings, right? So it's just a one-time underutilization in the 22 budget adjustment that is dropping to the bottom line, if you will, but it's not continuing in the future, but it is what they are experiencing right now, but it is not anticipated to be there in 23, if that helps.
No, but that's okay. I get it. I understand what they're doing, but
yeah.
In terms of long-term planning, it's antithetical for me to think of that. Okay.
And Madam Chair, if I might add, and we should obviously ask DCF, the commissioner, to come in and speak to this, but my understanding is also part of this underutilization is because of their tech database issue. And we got testimony directly from them earlier this session, just a couple weeks ago, saying they were fixing that and that they were going to get payments out within the next couple months. So I'm a little concerned that they're sort of giving up the money before they fix the tech issue. And so
that we will have, we'll have DCF in and we'll try to sort that out, because this is an issue, I think, of concern.
Yeah, we can't be not giving childcare funding out given everything that's going on. So let's get him in to speak to us about it.
Yeah, maybe Commissioner Radke. We'll see who shows up.
Yeah, and I'm taking some notes for follow-up as well. So I can, if it's helpful, I can reach out to them just to make sure they get the context so they're prepared.
Thank you.
That'd be great.
Yeah.
So number 16, there is $6 million of state fiscal recovery funds directed to the Vermont Food Bank for pandemic-related food assistance and to continue to help with food insecurity. Okay. Moving on to the Department of Disabilities, Aging and Independent Living, Dale. There's $1 million of state fiscal recovery funds for the adult day service providers to fund their operations through June 30th of 2022. If you recall, last year's big bill did include funding to sustain those providers. And so this is the amount of funds that are needed to support them through the end of fiscal year 22.
So it will be interesting to hear from Dale also about where our adult days stand in terms. I think we've lost one or two of them, but trying to figure out, are we ever going to resuscitate? We're going to need them.
Yep.
Go
And
ahead.
again, yeah, to your point, this will be a conversation for the 23 budget as well. Budget adjustment for Dale includes some initial funding for long-term care oversight initiative. One of the priorities of the former Secretary of the Agency of Human Services and current Commissioner Monica White is to provide additional staffing to provide this enhanced level of oversight at long-term care facilities. And so this is a kind of initial tranche of funding to support some additional positions at Dale to be able to perform that. And there is $150,000 gross to support increased caseload in the brain injury program at Dale.
Okay, there's nothing in here for respite. What the concern I think that I and others have had is about the extreme stress and pressure placed on caregivers. But there's nothing here. Well, adult day help, that does help. But
I should have clarified, if I did, my apologies. In the retention proposals, that is also intended to go to independent direct support workers, which I think could potentially get at some of the respite concerns you're expressing.
Okay. Okay, we'll try and sort that out. Thank you.
Yep.
Sarah, can I ask about the long-term care oversight initiative? And again, maybe this is a question I should ask the commissioner, but is that oversight of the operations? I mean, I know there's been some concerns about that, or is it oversight of who's overseeing whom or what?
So it's the Dale staff overseeing the long-term care facilities themselves. So probably their operations from a quality perspective as well.
Quality and compliance and
yes,
patient care.
Exactly.
Excellent.
Exactly.
Okay. Yeah, if we could get a little bit more information about that. I mean, it sounds like it is a thing I'm glad we're doing, but I'd like to know more details if we could get it.
Definitely. I think it's several positions at Dale that would be providing just additional resources for Dale to do more of this oversight, because I think, in recent years, there have been several issues where it was clear that resources were needed in this area, but I can get for you as follow-up a more kind of detailed plan in terms of what specific types of positions and what their initial focus will be.
That'd be great. Thank you.
Yeah. So, and listen, as we perhaps move ahead on some of our long-term care work, our bills, we'll have folks in to help to talk through this. There's also the Family First Plan. There's a whole bunch of things that may relate. So we'll look, we'll try and do that.
Great. So I think that's it for Dale and the budget adjustment. The next, for the Department of Health, the House added $167,000 to support 4 statewide syringe services programs. If you may recall, this goes back a few years. There were some one-time tobacco settlement funds that the Agency of Human Services, with the approval of the Joint Fiscal Committee, allocated to 4 different providers for syringe support services. Those funds came to an end, and so this $167,000 will fund these organizations through the end of the year. And then the Vermont Veterans Home. There is funding. We've already talked about the relationship with the retention proposal, and there is funding to support the staff at the Vermont Veterans Home. There was also money that was provided to support their increased costs associated with traveler nurses, as well as personal protective equipment, PPE, and some miscellaneous operating and repairs that the Veterans Home needed was funded in this budget adjustment.
So at some point, I know appropriations looks at the VA quite a bit, and we get involved with it from time to time, but at some point it would be helpful to understand what contribution the state makes as compared with what the federal government makes for the VA. I don't know that that's exactly your responsibility, Sarah, but it's an ongoing concern. And honestly, we do want to look at it at some time. That's all.
Yeah, that's, I think, definitely something that we can help you with in terms of looking
Okay.
at the funding mix at the veterans home.
Terrific.
And then the last item that I think is of relevance in the human services realm is that there's $55 million of funding that's going to ACCD for VHCB for housing and increased shelter capacity. It's made up of both general fund and state fiscal recovery funds. And this is in addition to some of the initial investments that were made in the big bill last year, a continuation of that.
Okay. And we haven't looked at the governor's budget as a committee. Is the VHCB being fully funded in that budget? Do we know? Okay.
In the budget adjustment?
No, in the big bill. We don't
Yes,
know.
I
That's
believe
okay.
it. Okay.
And then one of the requests that this committee made 2 sessions ago, I think it was pre-COVID, was to allocate and appropriate housing funds where there are places of greatest need in terms of mental health, transitional housing, and to really identify how to reduce the needs by placing housing where it's critical. So do we know if that, we'll have to ask of VHCB if that program is continuing?
Yes.
know.
I do
I
know
ha-
in an area for maybe future follow-up as well, last year's big bill appropriated $4 million to DMH for housing in community settings. And it would potentially be useful to get an update on the status of that.
We'll do that. That's good. So I do have a couple of questions. I think we've asked questions right along, and we have kind of a picture of what's there, and then things that we'd like to know further, in particular around the child development division issue, and then a couple others. But there's nothing explicit in here in this money, a couple places. It looks like primary care is subsidized through the Medicaid rate increase rather than any kind of a stabilization grant. Do you know if the agency did an analysis of those primary care practices that are going under without stabilization? I know we've heard of that consistently. And
Yes,
the rural areas of the state in particular.
I'm not aware if AHS or DEVA did a specific analysis on primary care practices that may be under specific duress, but I do know with the rate adjustments that are being funded in budget adjustment, and then again in 23, some of those increases are targeted towards primary care practices.
Yes. I mean, and so that's kind of the substitute, I would think, that we're seeing here, because we've heard from people that from our primary care folks, and I wanted to raise the issue that there's nothing here for primary care yet. There is something there through rates, and we'll be looking at that going forward. Certainly. And that the other thing, I think, Nolan, did you want to chime in? No. Okay. My other question is there anything, as we were to dig deeper in here, is there anything on our prevention services, our intervention and treatment services? Because we've seen an escalation in substance use disorder and suicide. I know there's something there for suicide, but is anything in here for our the
I
other
think
areas?
nothing specific beyond the syringe support services that I mentioned. And I'm sure this committee is aware, as we look to the 23 budget, the governor's recommend includes $8 million for, various mitigation efforts.
Okay, and as we look into the issues around mental health, that will also become so key. I spent yesterday talking with some child mental health experts at a board meeting, and it's devastating what's happening right now. Senator Hardy.
Thanks, Madam Chair. Sarah, the rate increases, where are they on your list, or did you say they're coming later?
Sure. If you go on page 2 of the document underneath DIVA, it's number 6, adjusting the Medicaid rates for participating providers. It's 4.7 million gross.
Okay,
and so within that.
Oh, sorry, go ahead.
Within that dollar amount, there are funds that are going to primary care providers.
Okay,
as
but
rate
this
adjustments.
is for all Medicaid providers, not just primary care. So primary care would obviously
correct, but I do understand that it makes up a good
Big
portion of that increase.
Okay, and then the other question is the specific. Is there language included in the bill that's not on your list that's in our area? Specifically, I'm wondering about the expansion of postpartum care for Medicaid recipients.
So that's,
I never expected you to bring that up.
I know I'm so predictable, aren't
Yeah,
I?
it's okay. Good question, Senator.
I love to be consistent.
It's good.
So that is not in the House version of the budget adjustment. I think, as you're probably aware, it is in the governor recommend for FY23 to extend that coverage. And I expect that this will be a conversation in the Senate for budget adjustment.
It will. As Senator Hardy knows that there's a 5-year window, I guess, within which to do this. But the quicker we do it, the better off we are.
Yes.
Yeah.
Okay, great. Thank you, Sarah.
Senator Hooker.
Thank you. Sarah, I want to go back to the housing piece. And how does that intersect with like the hotel programs for emergency housing?
Yeah. So the reason I thought it was important to include on this list is, as you know, we still have too many Vermonters who are living in hotels. And one of the challenges of moving them out of hotels is having available and appropriate housing for them. And so that's why the significant investments in housing that are being made are so critical to being able to move Vermonters out of hotels and into permanent housing. And there are, as you know, a lot of efforts underway to be able to do that, but the actual development of housing stock and increased shelter capacity is key to being able to do that.
And that takes time. So in the interim, what's happening? Is there money in the hotel programs? Is that what we're going to be counting on?
Great. So there is actually some language in the House version of the budget adjustment that signals intent to maintain that critical hotel motel program that is in operation. It's currently being funded 100% federally by FEMA. As of right now, we know we have FEMA funding 100% money through April 1st. There has been some discussion about whether FEMA will be extending that beyond April 1st. I believe Commissioner Gresham from Finance and Management did provide some testimony that, we are seeing some signals that it's a possibility that the 100% FEMA funding will be extended beyond April 1st. Even if it's not, there is still 100% federal funding available in the Emergency Rental Assistance Program that the state will transition the fund source for the motel program if and when FEMA funding goes away.
Okay. Any other housing? Yeah, I don't know whether this is the time, but certainly as we're going forward on the big bill, we're going to have to have housing folks in to go through this. I always feel like budget adjustment is shoring things up that may be needed as a result of what was missed the time before. but we do have a lot of very important questions to ask. But maybe we'll see how it goes, but we'll bring some folks in to get more information. And Sarah, my question is, is there a way that we can get the isolated language, the AHS language, cut out of the bill and if you can send it to Aaron and put it up, then that way we'll be able to see what policy decisions are there.
Yes,
and
I
those
can
go.
definitely do that.
That would be so awesome.
Yep.
Thank you.
Mhm.
Committee, other questions for Sarah while we have her? There are a lot of questions, and this is our first look, and we'll be talking with appropriations. I'll talk with Senator Kitchell a little bit. We can, and we're going to have to talk through this. I'm not sure that we're ready to do that today, but we've identified some areas that we're concerned about, and we're wondering where they are. It's something missing, or why the decision was made that was made. So we'll have to come back to this. Senator Hardy.
Thanks. I don't have a question. I just wanted to thank Sarah. It's nice to have you on our team and to get this comprehensive summary. So thank you.
My pleasure. I think if I may, one last thing from a language perspective, and I'll send it all over. I think probably the biggest kind of policy related area for the language is with the retention program. And so I think it aligns with how I described it to you, but I think you'll want to focus on that.
Okay. Yes, good. Yeah, I know the concern about our nursing home staff and others who are maybe in less professional levels of care. We've been very concerned about retaining them and attracting more. So we'll look at that with that thought in mind. Senator Cummings, are you all set? Okay. Senator Hooker? Senator Hardy? Good. All right. So Sarah, yes, thank you so much for being here. It's a comfort to have you on our team. And
Glad to be here.
Good. You'll be back. I think we're at the early stages right now, early stages meaning, and it's going to go extremely fast. We also understand that, but the child care issue is what's happening to that over $800,000. And then how is the Medicaid reimbursement being distributed? This is not necessarily, these are not questions that you necessarily can answer, but your thought would be helpful. And then some of the long-term care, we'll look and see what the policy states there, and we'll try to sort that out. We have a long-term care bill on our wall that raises long-term care rates, and that may become part of some recommendation, Medicaid type recommendation going forward. We'll see how that works. Senator Hardy, go ahead.
Sorry, I thought of another question. Sarah, I'm looking at my list and your list. I was surprised there's not more in mental health. So I'm wondering, is there anything in children's mental health that's in the education area for schools? Or
I don't believe in terms of changes within the budget adjustment construct, but I think it's a good question as we look to 23, but not within the budget adjustment construct specific to children's mental health.
Yeah, that's such a good question.
There's an emergency situation right now in our schools. Like I live it pretty much every single day as a mom with kids in schools. And it seems like it's a budget adjustment issue if we can get some help to schools for mental health.
So this is exactly the reason why we're taking up 194, 195, and 197. And we're going to be bringing in people from the earliest age to the oldest adolescent through adolescence. Our mental health system is in absolute crisis right now. And the question about what is it that schools need, obviously it could go through AOE, but I think that as we talk with folks we're going to identify that they're looking for help outside of what educational institutions can do. And so some support services that might come through an AHS type organization, DAs, SSAs, what can we do? So these are the questions that we're going to be looking at. Maybe there is a short-term fix. Maybe there's a bridge that can be made, because this, to me, this is just like number one on our list. Just so critical.
Yeah.
And then beyond that, the substance use disorder piece that we're not hearing enough about. But go ahead, Senator Hooker.
I'm just hoping that we can find some resources, especially since the DA's appropriations have been cut, and we need to, enhance that so that we can respond to this critical need that Senator Hardy is talking about, and especially in schools. I mean, I'm seeing it down here. I don't have kids in the schools, but I have nieces and nephews and great nieces and nephews who are concerned about what's happening in their classroom.
So we'll tackle this one. We'll be picking this up, but also remember that a lot of subacute beds are closed down. We have to figure out how to open those up, because that's where kids go after the ED. And so it's the prevention piece is in the schools. We got to do that. And then we have to get them out of EDs and into some facility that helps repair them and then move them back home. So anyway, there's nothing in the budget adjustment that looks like any of this to us, is there, Sarah? Don't know.
No, I
Okay.
don't believe so.
But
All
maybe
right.
we can get something in. Oh, Nolan's waving his hand. Do you have something, Nolan?
I do. I just sent it in the chat, but I'll send it to Aaron to post online too. Is the DIVA narrative? There were questions about why the ACO is getting the money, the contractual stuff. There's questions about the Medicaid rate piece, and these narratives provide a little bit more detail as to DIVA's rationale for those things. So that might help, and to the extent that you want deeper understanding of those things, and reach out to me and I'll reach out to DIVA to get a deeper explanation. But I think that those kind of help maybe understand one step down the rationales for those specific.
Thank you. That is helpful. That's great.
And
And these are these the little white papers that Diva shared with the House?
yes.
Yeah. Okay.
And I'll
So-
send it to Aaron so you can post. So
Okay.
that the public can watch or can see it as well.
Okay.
Yeah, the ACO is number 10, and the Medicaid rate adjustment, I think, is number 9. So on that.
Terrific. Okay.
Or Aaron can grab the link off of this. Actually, Aaron can just grab the link off of this.
Okay. Aaron will do it, I'm sure. Any other questions or things? I know that I talk a great deal about mental health, and I want to keep that conversation going, not just through budget adjustment, but forward. Anything else for our joint fiscal? From joint fiscal? No, we're good. Okay, thank you.
Thank
We're
you.
going to move into a little bit of committee discussion briefly, and then we're going to wrap for the day. So thanks a bunch. So the other day we heard from, and believe me, mental health is a huge issue. It's just, and everybody wants to solve it. And what we need to do is to identify, we need to have the leadership to make it happen. And we're going to try to do that. Last week, we heard from the task force, and we started to look through the task force. And as I was listening to the committee discussion, it occurred to me that there's a great interest in the moderate needs group, and then possibly some interest in the blueprint and looking at a blueprint expansion. So I'm thinking that as we go forward, it might be helpful to think in those terms. And I didn't hear a lot of enthusiasm around the cost growth benchmark piece or the public option. So and each of those has its own place to be, though. It may end up that as we're talking about moderate needs group or an investment in a specific number of people over time, what's the return on investment for that in the short term and the long term? What's the benefit of our current blueprint, and what's the return on investment for the longer term expansion of a blueprint? So, and within the blueprint, we have elements of primary care that help with prevention, and so might increase the long-term return on investment. So I've been thinking in those in that way, and how we might build a committee bill. And I asked Jen for a committee bill placeholder, so that as we go forward with the task force work, we might want to have a committee bill on that. And then we can add in elements of other bills that we have in committee as we look at those. You know, for example, we'll look at S244, which is the primary care bill, and there are elements of that we may want to put into a committee bill. We could use that for a vehicle. It's not, nothing is ever cut in stone, but so just some thinking that I was doing when it was really cold out the other day, and nobody wanted to go out. So some thoughts there, and we'll bring this into a conversation. We will come back to the task force, and we're going to be bringing some of the bills in that we might want to integrate in some way. So, some thoughts there. Go ahead.
Thanks, Senator Lyons. Ginny, whatever. Hey, you. Thank you. I appreciate that you heard that the moderate needs group was the thing that was most interesting. That was definitely of the four, the one that I would be most interested in pursuing, especially given what we're hearing out in the field. The blueprint for health, what I would love to start with, and maybe Nolan can do this, is just a better explanation of what the blueprint for health is and what it does. Every time anybody talks about it, it's so darn vague. I have no idea. It sounds like a really lovely thing, but I don't know exactly what it does and who participates in it and how it works. So if there is something already available to send us, that would be great. But that's where I'd like to start on that, because I don't even know if I want to expand it, because I'm not sure what it is.
Okay.
So I guess the question is, do you just want material on it, or do you want to actually hear from, they just hired a new blueprint director, or oversees?
That would be great. The blueprint director, and then something in writing about what it is, just like a one-pager even. It's just every single time, and I said this last Friday to Josh, I'm like, this is just vague. I just don't know what it is. So
we'll do that. And I also encourage you to read, I think it begins on page 41 of the task full report about blueprint expansion, to just look at that. And then page 18 is the page that the moderate needs group begins on, and just read that, because that'll help reinforce what we were hearing a little bit, and maybe expand a little bit. Then we do certainly have questions about the foundation, what is blueprint, and we'll try to get some of that information in, and then answer questions about the benefit of expansion. So there are all the important questions that we have to ask. For me, I'm very interested in understanding how whatever decision we make affects how many Vermonters. So if we're looking at expanding the moderate needs group, and we're expanding it for 400 or 500 people, those, as we know, are people with very high needs. So it might actually be a significant investment. Then what is the return on investment? So there are a lot of questions that we have to ask about numbers of Vermonters, benefit over time, Will it prevent, will it prevent high costs later on? You know, all those things that are of concern to us. And will it promote access? So obviously, getting people off a wait list is a good thing. All right, Nolan, go ahead.
Yeah, and I just sent the link to the Blueprint website, and on the website, there's lots of information about what it is. Also, the annual report is a nice document in terms of laying out what it is, how many people it's affected, et cetera, et cetera. So you might start with that, and then Senator Hardy's correct. You might want to get a little background on Blueprint before taking the next step.
We'll do that. Okay, I don't know whether we'll do that before we take the next step, but we'll do that. Okay, so Senator Cummings.
Yeah, as we're going forward, the thing I am getting the most emails on and I find most concerning is we've talked about mental health needs and our mental health crisis. And my local, I got an email this morning, my local mental health agency is having us all in at 8:15, my favorite hour, next Monday, because it is Mental Health Advocacy Day. And I know last year they were struggling, but I haven't heard, the complaints I'm getting is the lack of response from the Department of Education to this whole crisis. The stress levels across the board, parents, children are through the ceiling. The stress, and there, I heard nothing in the governor's budget address, at least, talking about what are we going to do. You know, we're all concerned about how many days we're missing and expanding the school year. But what are we going to do this summer, going into next fall, to make sure that those kids get the educational, which is in our domain, but the kind of just mental health services? You know, a lot of these kids are going to be very discouraged. And if we don't help them feel better about their academic performance, we are going to have some big problems down the line. And I'm just not clear what's happening, but I haven't seen any clear response. I don't know.
So I think you're asking such a good question. And Senator Hooker and I have been sitting in education listening to folks as well. But, and this is not a new issue. It's exacerbated by the pandemic. We have seen acute needs in our schools for mental health support and other support services that don't reach the level of acuity that some of them are today. We continue to see that. And we continue to see, for me, and I'm sorry, I don't know who I'm going to insult with this comment, but the Agency of Education is very concerned about curriculum. And the concern about curriculum is a good one. Mm-hmm. But the counseling side of things in the Agency of Education is at a level that may not be responsive or capable of being responsive to the acute mental health needs that we're seeing today. Mm-hmm. Therefore, I mean, what it leaves then is the Agency of Human Services providing for support to our educational institutions. And then that is a comment on our workforce availability and on how our designated agencies can help, or the NFI group can help with ameliorating the problems that we're seeing in school. So it's a very difficult situation, and I am cautiously, I hate to use the word optimistic, but I'm cautiously optimistic that we can do something to provide the support services that schools need. There has to be a creative response in this to help. And kids are just having such an awful time in school. It is so clear. But they're also having a difficult time when they get home, and then they go to an emergency department, and there's nothing in the community to catch them. So we have a heavy lift here. I go back to, I won't go back to that now, but there are other issues here that we need to deal with. But so some of the people we'll hear from this week will talk about what's needed in schools and what schools are doing. But it's just one person coming in on that one, because this is a crossover between education and healthcare, and Senator Hooker and I are keenly aware of that. So we will work together. I'm looking for you folks to help bring forward some ideas that help us step forward, among others. Oh, Senator Cummings, you triggered. I'm sorry. I don't mean to
That's good.
speechify.
No, one of the most horrifying experiences I had during my tenure on education was hearing the level of violence that was present in schools. One of our witnesses actually had to cancel because they were going to the emergency room in an ambulance. And these were second and third graders, okay, not adolescents. My mental health agency actually has a school where students that are struggling in the mainstream school can go. That was pre-COVID. Those children have now been shut at homes. Many of the homes are not ideal. Parents are struggling. This kind of just being closed in makes everything worse for everyone. And that to me is, we need to know what's going to happen. I think the numbers are starting to go down with COVID. I heard 500.
All the way down to 500.
100. I know, but it's Monday. So let's see. But it's gone from 27 down to 15. I mean, I'm waiting for 200 again when I thought that was high, but it's starting down, and kids are back in school.
Mhm.
And we need to find a way to support teachers. We need to find a way to support kids and our mental health agencies. And it really needs to be a call to arms to the state. Bad analogy.
Well, yeah.
But I mean, it needs to be a concerted effort.
Yeah, let's see. How about, we need a different analogy, Senator.
Yes, I know we do.
Yeah.
We need to rally around this issue.
So I think as you're, as we're all sitting here thinking about this, that bringing in Holly Morehouse again from the after school program, which was initially started for, mitigating social determinants and providing behavioral mental health support, that's an important one. It's got school in it, so education picks up on it, but it's also after school, so we can pick up on it. I think working together, we can listen and see what is coming and then what might be helpful.
Yeah.
before.
And, as I'm looking at the whole weighting study and some of the swings in funding and talking about, there's an assessment mechanism.
Mm.
I remember Holly and kids learn at about the same level until you get to summer. And then the kids that don't have access to libraries and parents that have time and energy to read to them, or any kind of camp or intellectually stimulating programs, decline significantly more over the summer. And can we use some of those additional funds to set up something other than soccer camp, which is fine. But
Well, let's find out what does happen, and
I'd
then
like to
we'll,
work
yeah,
with that.
yeah, you're right. And having the food bank supported over the summer so that kids are
Well,
getting
we've done a feeding
nutrition.
program that's
done a
been
great
good.
deal. Yeah.
Yeah.
And
All right. Senator Hooker.
we're going to be hearing from Holly Morehouse this week in education about what's happening in the the out of school programs. So that'll be helpful. I just want to I hope that the monies that we have are being appropriated appropriately. I know that money isn't going to solve all of the problems, but certainly our community agencies need to have enough money so that they can pay their help for all of, especially extra work that's happening due to the pandemic.
Yeah, it's a heavy toll, and having people available to work with kids, whether it's just the teaching tech in the summer or soccer or whatever it is, just having adults as good, solid role models or older peers, so critical. All right. Committee, we get the drift. I think we're all thinking and try how to solve some of these really difficult issues, and we will do that. And we'll work together here, but we'll also connect laterally with folks in education. Okay, I'm going to, Aaron, suggest that we could probably come off of YouTube, and we're going to be ending up